Good afternoon. Thank you for attending this webinar. My name is Sonja Dieterich. I'm a medical physicist at the University of California in Davis, which is actually in Sacramento, California. And I want to talk today about IGBT, image-guided brachytherapy with BodyTom in a tiny procedure room. The idea for this title came to me because my son was very interested in a documentary on tiny houses, and this tiny procedure room feels like the same, where you have to pack a lot of features and a lot of functionality in a very, very small space. So just to give you a background of what my clinic is like at the University of California, Davis. So in terms of external beam, we have 2 Electa linear accelerators. They treat about 60 patients a day, and a tomotherapy HTA unit. The workload is about 20 patients a day for a total of 80 on average. We range anywhere from 70 to 100. And our simulator for these 3 machines is currently one Philips Big Bore CT simulator. It's pretty busy, as you can imagine. We also have currently a GYN brachytherapy program with a gamma med and brachyvision. We're treating about 100 patients for about 350 procedures per year. We do the occasional breast or surface or endobronchial case, but our majority is GYN. We also have prostate HDR. So we recently moved from our LDR program to HDR with an on-central prostate planning system and a Flexitron afterloader. It's currently at 20 patients per year, but rapidly ramping up. And also Gamma Knife and Ray Station and MIM. So the need for image guidance in the brachytherapy suite became very clear. So in 2012, when I joined UC Davis, we had a busy HDR program, but when you looked at the type of patients we had, they were straightforward cylinders, tandem and rings, and the occasional breast or interstitial patient. Flash forward to 2020, 8 years later, about 50% of our cylinder patients have freehand needles in addition, and more than 90% of our tandem and rings have additional freehand needles. It's actually quite rare to have a straightforward tandem and ring. I'm very surprised when I see these in treatment planning nowadays. And the main reason for that is that we had a pretty significant change of referral patterns, where patients from the vast rural areas of Northern California receive external beam treatment at their smaller hometown radiation oncology department and come for their brachytherapy treatments to us in the academic medical center. We also have an increased external beam census with increased demand on our simulator. And increased brachy census, it keeps going up, and increased complexity. And we just couldn't find a way to accommodate both the external beam increase in census and the increased brachytherapy load with longer procedures on one simulator. But what we had was one available cozy, tiny room from an old style 2D simulator, which had been a procedure room. So when you look at the IGBT suite, I just want to show you a quick video of how the BodyTom moves and how it sets up. And I'll start a little bit later. It's just a few seconds. So you saw at the very end, there is the treatment room and there is a console area outside. In this case, we had the door closed because it's after hours, but you saw in the video you can leave the door open and just behind a shield because the BodyTom is self-shielded. The scatter radiation gets absorbed by this plastic shield here. And this is actually very comforting for the patients and also the anesthesiologists and our radiation therapists to have eye contact and audiovisual contact with our patients while we're scanning. So this is our tiny procedure room. As you can see, we're pretty tightly packed in there with a lot of equipment. And let me switch my laser pointer on. So we have the BodyTom parked pretty close against the wall here. I barely can fit behind it. We have a springboard type couch that can accept the stirrups on the here. We also have a couch, an additional gurney with a Diacore Zephyr system, and I'll explain a little bit how we use that. Back here sits our gamma med. We have a crash cart, supply cart, an anesthesia beam, and on this side here, which you can't see, is a bunch of shelves and a sink and an ultrasound tucked in the corner here. So we also had, because the procedure room wasn't designed for HDR, we had to put in additional shielding, so which brought the ceiling lower. And this back wall is actually a fake wall hiding a lead shielding lead brick shielding wall. As you can see in this room, we need a second gurney because our volume is so high that when we implant these complicated cases, we often move them from the springboard couch to the gurney with the Zephyr, take them out of the room. Our dosimetrists start planning the case while we, for example, get a cylinder going or get the second case going. Then when we've treated the second case or the cylinder, we can take them out. I'm sorry, this is my phone. I'm on call today. Hey, can I call you back? And so we can treat the second patient while the more complex first case gets planned, and then we can bring them back in. You can also immediately see visually why we could not have possibly put a standard CT simulator in this room with a fixed couch. There is some room you need behind the CT scanner for a fixed couch to move the couch through the scanner. And in addition, if you have a fixed couch and a patient with stirrups, it's very hard to actually get access to the patient once you don't need imaging anymore. So this was the main reason why we decided we need to go with something else, and we looked at the CT on rails, CT on wheels, and then one of our radiology physicists said, hey, we have a Ceratom in our ICU, take a look at this. These guys are developing a full bore CT scanner with this kind of the same technology just for body scanning. And that's how we started talking to Neurologica, and we're very impressed with their system. So in terms of location and motion, you can see here we've got the BodyTom parked pretty close to the wall back here, and we've marked its location with tapes on the floor, so we can actually see if we accidentally introduce a rotation to the scanner or if it gets a little bit skewed. The table central axis here needs to be aligned with the BodyTom motion axis to get an accurate CT scan that is not accidentally skewed. This is fixed mechanically in traditional simulators just by the fact that the couch is mounted relative to the CT scanner and the CT scanner is not moving. In our case, we had to figure out a way how we make sure that over time with a system as mobile as the BodyTom and a standard OR couch, that we didn't have a shift in these two vectors that made them not parallel. So what we're using is actually the BodyTom external laser system. And we're doing this as part of the morning QA, or therapists performing this check. And after they do the morning QA check, the couch gets locked in position with the brakes, and the brakes do not get released during the day. If we're moving the BodyTom a lot during the day, if you have more than 3 cases, we do another double check in the late afternoon. So what we're doing is basically we're using the external sagittal laser here, this one, in addition to these and the bore laser. So we use this one against the couch central axis. And we're moving the BodyTom. We have a ruler on the couch, and we can double check that both these motion, the couch central axis and the motion axis, agree within, we have a tolerance of 2 millimeters. Here's dive board couch. You can see that we can lock the brakes here, and we also have marked the position with tape on the floor. So if there's any large inadvertent motions, somebody bumps into the couch, we would immediately spot that visually. We also check the distance to scan start as a way to see if the BodyTom motion distance is accurate over time, and we've set that up in our system as 277 millimeters. That's what we needed. It's configurable. This is our value, and this is usually within tolerance of 1 to 2 millimeters. And that is equivalent to moving the couch in a standard simulator relative to the CT and measuring, confirming that the couch motion is accurate. So it's basically the inverse. For patient setup, I talked about the springboard couch, and we found when we had a patient in lithotomy position that there's quite a bit of sag in the couch, and GYN patients can be very heavy, which increases the mechanical load on the system. And so what we came up with, this is how it actually looks like when we're doing a GYN case. We have the patient here on the cephers, so we can move them up and down the couch as we want. Behind the BodyTom, you can actually not see that. The patient is in stirrups. You can kind of see her knees here. And our whole HDR implant team is actually behind the BodyTom because there's now about 2 meters of space there. But you can see how far the patient is extended on the couch. And so what we came up with is a home-built table support system. You can see that here. And after the patient is in place and the BodyTom is in the start scan position, we actually can move this here so we can make sure that we don't have a collision during scanning. So we feel safe about that. And the patient is physically supported, even though we're not out of spec of the Zephyr, but it's just an extra protecting all the mechanics from wear and tear over the time. In terms of other BodyTom QA, we in general follow for annual and monthly QA the recommendations of TG66. There's also an upgraded task group in the works, and once that gets published, we will update our QA as well. We found, as I've talked about, we need to do some modifications for mechanical and couch checks, because in our case, the couch is fixed and the scanner is moving, and the couch versus the scanner are not fixed to each other. So we made some modifications to these task group recommendations. The morning QA for the image quality is actually very nicely integrated in the graphical user interface for BodyTom. So it's very easy for the therapists to just mount the image QA phantom in the morning, do a quick scan. BodyTom doesn't automatically analyze the images and gives the results, and physics can just come in and checks it quickly. We actually, when we commissioned the BodyTom, we took the QA program we had and all our worksheets from our Philips CT simulator and just adapted them as needed. And we found actually in terms of values of resolution and noise and HU density, slice thickness, very, very similar results to our standard Philips simulator. In terms of image quality, you've seen some images. This one really convinced me that we're on the right track here. This is a standard scan of a tandem and ring implant, and you can, if you look closely here, you can actually see the internal channel of a tandem. And that, to me as a physicist, if I can see the internal channel and actually the tip of this channel, indicates to me good image quality for the purpose that I'm imaging for, and that is identifying the applicator. this is in a more heterogeneous area of scanning. This is one of our few endobronch cases. And you can see that we can very clearly see the dummy wires here in the channel. Metal artifact reduction, a very important topic these days. It is currently available for axial imaging protocols. Our current protocols are all helical, so we haven't implemented yet, but that's my next project actually on the BodyTom. And I hear from Neurologica that helical metal artifact reduction is coming soon. My thoughts where I would apply that is the Savi applicator, because the Savi has a lot of metal pieces which make it a little bit hard to identify the applicator tips. We've also had situations where I had gold fiducials near needle tips, which made it sometimes hard to tell exactly where the needle tip was. Also, patients with hip implants, interstitial patients especially, can be very challenging, and applying a metal artifact reduction algorithm could really help in improving the treatment planning quality for those patients. When we installed BodyTom, the question came immediately up, can we use this as external beam simulator? You know, what happens when your CT goes down? And this year we unfortunately did have that situation. Our older Philips big bore CT crashed hard and was down for 2 weeks. And shifting all of our patients 5 or 6 per day onto radiology was really a burden on our radiology colleagues. And then when the decision was made that we get a new CT scanner, we also were down for a further 2 weeks. So we thought about it very hard, and we came to the following conclusion. Image quality clearly was up to par with what we needed. The crux here was this couch access to BodyTom motion access issue that, you know, you can have some shifts there. There can be some rotation of those two axes versus each other, and our tolerance is 2 millimeters for that, reasonably. So we decided that we would accept the BodyTom as a simulator for our palliative cases. They usually have large margins, so whole brain, extremities. For our standard 3D patients, so the pelvis patients, if the fields were relatively short, because then even if you have any skew between the table axis and the motion axis, it would be below what, you know, would be part of the systematic error that we account for in our PTV anyway. And we also simulated select IMRT cases, for example, larger pelvic lesions where we felt confident we can have a margin that would accommodate any potential uncertainties in the imaging. So what about VMAT and SBRT in long fields? It turns out that Neurologica has a solution that they implemented for a proton facility. And that is a floor rail that you can install, and it can actually, my understanding is that it can come off the floor when we don't need it, so it's not a trip hazard, but you can install it when you need it. And that floor rail would bring the motion axis, would fix the motion axis over time, over a more extended time. And if I had that, and we're seriously thinking about installing that, I would feel very confident of using the BodyTom as a backup to our regular simulator for for cases that require higher spatial accuracies. I should mention that skew that I mentioned, if you move it back and forth a lot, it is a very slow skew that happens over a long time. For the back and forth motion you have in a typical brachytherapy program, that would be for us about 400 procedures a year. But that being said, as this room is fairly new construction, when we renovated it for brachytherapy, we put in a completely new floor according to the Neurologica specifications. So that certainly helps. If you want to change the room configuration, you need to recalibrate the BodyTom to adjust for the change in flooring, but it's a half-day procedure. Our engineer has done that for us, and it actually works fairly well. With that, I want to say thank you to our team here at UC Davis. We currently have 4 physicists. We're hiring for junior physicists currently, and 6 physicians. And thank you very much for your attention.